My dear students, in this video, I am going to discuss some points about a TB patient in shock. Let us start with this case scenario. A 42-year-old male, a known case of pulmonary tuberculosis, who was on ATT for 3 weeks after recent diagnosis, is non-compliant, and he presents with fever for 2 weeks, progressive breathlessness, altered sensorium for 6 hours, and decreasing urine output for the same duration. On examination, his BP is 78/42 with a mean of 54 millimeter of Hg. Heart rate is 128. Respiratory rate is 32 with a saturation of 86% on room air. Temperature is 39.2 degrees centigrade. Patient is having cold, clammy extremities with capillary refill time exceeding 4 seconds. On chest examination, he has bilateral crepitations with some bronchial breathing on one side, and he is also having possible hepatosplenomegaly and lymphadenopathy. As you can realize from this patient, very clearly deduce that this patient is in shock. Now the question is, what is the cause of shock? This patient has been diagnosed recently and started on ATT on tuberculosis due to tuberculosis, and who is also non-compliant. So when we look in such shock in an active TB patient, we have to remember that this kind of shock is usually unique because it is never due to a single etiology. And because it is never a single etiology problem, there are multiple overlapping mechanisms, some of which may be more important or predominant over the others, but yet the others may coexist in the same patient. Like this patient, if septic shock may predominate in a TB patient, particularly in those who have disseminated or miliary tuberculosis following TB bacteremia, and in immune reconstitution inflammatory syndrome, which is a known complication of after ATT in some patients on TB. It can be even a cardiogenic shock dominant multi-etiological shock if a patient is having tubercular myocarditis and is also complicated with pericardial tamponade or with TB cardiomyopathy. A patient can have an obstructive shock if it is because of massive pericardial effusion or tension pneumothorax. The patient can have distributive shock. Distributive shock can also occur without septic shock if a patient is having TB adrenalitis resulting in Addisonian crisis. Or conventionally, the patient can also go into hypovolemic shock, particularly if it is a GI tuberculosis and patient is malnourished, having diarrhea, etc. Therefore, it is very important to know that if we delay treatment, this paper was published some 2 decades ago, but it identified a truth which was eternal, that delayed treatment contributes to mortality in ICU patients with severe active pulmonary tuberculosis and acute respiratory failure. And if we look into the plots, you can very clearly see that how the survivors are different from the deceased are different from the survivors in terms of the symptom duration and treatment initiation. If you look into these circles around the line and if you compare with the others. So ICU patients with severe pulmonary tuberculosis remain at high risk of death, and this is at least in part because of delays in suspecting and treating tuberculosis before as well as after ICU admission. So once the patient is admitted and the patient is a known case of tuberculosis who is presenting with shock, any delay in the treatment can be very detrimental for the patient. But before that, you have to realize or have to evaluate as to whether the shock is because of TB or TB is a comorbidity in a patient with shock. If the shock is caused by the TB, it is usually following disseminated or miliary tuberculosis, tuberculous pneumonia, pericardial tamponade, adrenal crisis. But it can occur because of other causes with TB as a comorbidity in patients with secondary bacterial sepsis, if the patient is having any hospital-acquired infection following drug-induced complications, massive hemoptysis with hypovolemia, etc. And this distinction guides the urgency and the treatment, because both are urgent. In both, the delay cannot be advised, or but if it is caused directly because of tuberculosis, it is more serious in terms of outcome. So septic shock is the most common form of shock. Septic shock, predominant shock, is the most common form of shock which occurs in a patient with TB, where TB acts as a chronic intracellular infection causing delayed but sustained inflammatory response, which, when overwhelming, leads to vasoplegia, leads to capillary leak, and leads to mitochondrial dysfunction. The clinical clues are obtained from due to high-grade fever, an initial occurrence of warm shock, which is followed later by cold shock, elevated lactate, and poor response to fluids alone. The unique TB aspect is that, in comparison to bacterial sepsis, this is slower in onset, but it is often accompanied by profound anemia and malnutrition, and it is frequently complicated by ARDS. If we look into one of those studies, which a literature review, you find that antibiotic administration is crucial. Antibiotic administration within 24 hours of the septic shock has been shown to improve mortality in patients with tuberculosis septic shock. So highest degree of suspicion and sputum nucleic acid amplification, that is the CBNAT, can be utilized towards rapid diagnosis and prompt administration of susceptible antibiotics. But if you think that this is the end, you are sadly mistaken, because the pathogenesis of tuberculosis septic shock is different in immunocompromised patients as opposed to the competent. So therefore, it is important, much though in immunocompromised patients, to start antitubercular therapy, ATT therapy. Initially, there can be paradoxical clinical worsening of patients with TB after susceptible antibiotic administration, leading to tubercular septic shock, but that will arise the possibility of that is reconstitution inflammatory syndrome. But in that case also, it is very important to distinguish between these two features and make it sure that there is no interruption in therapy of either due to tuberculosis or the antibacterial which the patient was on. Let us look into this famous study which was published in 2013 by Karthi et al. On Mycobacterium tuberculosis septic shock, in which the ICU patients with TB-induced shock were studied at depth. And if you can see the Apache scoring and the Apache quartile and plot against survival, you can see that although there is decline in bacterial septic shock, and the same decline occurs in Mycobacterium tuberculosis also, but the decline is more rapid. And with an Apache 2 quartile more than 30, you find there is almost no survivor in tuberculosis septic shock. And if you can see the other graph to your right, where appropriate and inappropriate therapies in the two groups have been compared in cases of survivors and non-survivors in both bacterial sepsis and Mycobacterium tuberculosis septic shock, where appropriate antibiotics means with appropriate timing of ATT and antibiotics, and inappropriate means delayed either in antibiotic or ATT, you can clearly, distinctly find the difference in the two in terms of the outcome. Therefore, TB shock itself declares only after failure of standard sepsis therapy. That has been the observation, which is very important to realize the fact that why there is delay. If you see the other varieties, you know that these patients can even be immunocompetent, that not necessarily all the patients will be immunocompromised. Even in immunocompetent patients, there can be shock, and this shock is usually the result of disseminated tuberculosis, and the clinicians should have a high index of suspicion for disseminated tuberculosis in patients with chronic symptoms and signs which affects multiple organ systems without any obvious cause. The second variety is the obstructive shock, which occurs following tubercular pericardial disease because of massive pericardial effusion, which impairs the diastolic filling and causes reduced cardiac output, leading to shock. The clinical clues arises due to raised JVP and hypotension, muffled heart sounds, pulses, paradoxes, shock refractory fluids, which is quite similar to patients presenting with pericardial effusion because of any other cause. But important to know that why it is missed, because fever and hypotension may be wrongly attributed to sepsis, and the clinical signs are subtle in ICU patients. Therefore, when you see the tuberculous pericarditis, this paper published by Mayosi, which was again a landmark paper, where you can find that if the population is endemic to tuberculosis, then a trial of empirical anti-tuberculous chemotherapy is recommended for exudative pericardial effusion after other causes like malignancy, uremia, trauma, etc. have been excluded. Although this trial is not warranted in areas where tuberculosis is not endemic and there is no justification for starting till the definitive diagnosis is written. But it is important that in our country where tuberculosis is endemic, any patient with exudative pericardial effusion who has been excluded of having malignancy, uremia, and trauma should receive ATT if the diagnosis, if tuberculosis is a strong possibility. They also speak about pericardial biopsy because other than the CBNAT or the ADA, which unequivocally supports our clinical diagnosis as well as the radiological findings, pericardial biopsy may be something important for the reason that there is a aspect of therapeutic biopsy alongside diagnostic biopsy. Diagnostic biopsy in areas in which TB is endemic is not required before commencing empirical antituberculous treatment, but in areas where it is not endemic, a diagnostic biopsy is recommended in patients with more than 3 weeks of illness without etiological diagnosis having reached by other tests. But therapeutic biopsy is an added advantage of pericardial biopsy because the surgical drainage in these patients with severe tamponade, in addition to the relieving the symptoms due by pericardiocentesis, can also ascertain this diagnosis, especially in non-endemic areas. So the management essentially relies on drainage with ATT and steroids. The patient can go into shock because of adrenal tuberculosis, where destruction of the adrenal cortex by the TB leads to absolute cortisol deficiency, and this produces a kind of vasopressor resistant shock. The clinical clues are obtained because of persistent hypotension despite giving high doses of norepinephrine. Alongside, patient has hyponatremia and hypoglycemia. Hyperkalemia may be present, but sometimes it may get masked because of other dominating features, and definitely, if examiner is careful, he will get a history of chronic tuberculosis. So always suspect adrenal crisis in tubercular shock when not responding as expected. There are no large studies, but there are numerous small studies and small reports where adrenal crisis after tuberculosis has been successfully treated by ATT as well as other adjunctive therapies, including ECMO in the emergency department. And in patients with refractory shocks, one has to remember steroids are replacement therapy, not adjunctive therapy, so that 50 microgram 6-hourly dose may not be required. Even a much higher dose may be actually required. 50 micrograms may not be sufficient. And it is very important to distinguish this adrenal insufficiency from adrenal crisis, because in the patients who present to the ICU, they usually have adrenal crisis following tubercular adrenalitis, which manifests as syncope, abdominal pain, confusion associated with other features like anorexia, discomfort, etc. And in those patients, the routine laboratory tests are more likely to yield this metabolic changes, including hyponatremia, hypoglycemia, hypercalcemia, etc., and they require more urgent therapy. In adrenal insufficiency, these patients may be less serious, and in these patients, if the patient is having a shock, then it may not be due to adrenal, but it may be because of other factors, which includes there can be distinguishing features that may be useful to identify them as adrenal insufficiency, and those clues include hyperpigmentation, anemia, hyponatremia, hyperkalemia, and eosinophilia. So what should be our considerations for treatment of adrenal tuberculosis? One should be administration of high-dose glucocorticoids and fluid resuscitation, IV hydrocortisone 300 to 400 mg in 24 hours, either as continuous infusion or in divided doses at 6 hours for both glucocorticoid and mineralocorticoid coverage, and to obtain plasma cortisone samples for plasma cortisone levels before administration of hydrocortisone. Prednisolone can be used if hydrocortisone is available, although that is a very rarity, but dexamethasone is avoided because of its increased incidence of Cushingoid's side effects leading to non-compliance. Fludrocortisone should be added in patients who have associated aldosterone deficiency. The next is the cardiogenic shock, which is rare but an important cause of shock in TB patients. The mechanisms may be because of tubercular myocarditis, sepsis-induced cardiomyopathy, or severe hypoxia. The clues are obtained by the standard bedside echo, showing low ejection fraction, raised filling pressures, and poor response to fluids, but better with inotropes. So in cardiogenic shock, you get poor response to fluids and better response to inotropes, but in the disease shock due to adrenal crisis, you get the response to inotropes is equally poor. And if you look into the heart failure and cardiogenic shock, you can see that there has been an association of the two with immune reconstitution inflammatory syndrome, because although immune reconstitution inflammatory syndrome was classically observed in TB following HIV after beginning of ART, the same has been seen in large number of patients following ATT, and this points out to the disease because of high pro-inflammatory cytokine concentrations, which leads to DCMO, that is dilated cardiomyopathy, and that can produce the heart failure. So DCMO could develop overt heart failure as a consequence of IRIS. And last but not the least, it can be because of hypovolemic component involved in tuberculosis septic shock, and this occurs mostly in patients with chronic tuberculosis with dehydration, poor intake, GI involvement, loss due to third space, etc. The clues can be obtained from dry mucosa, low JVP or collapsed IVCs, and rapid response to the initial fluids. So whenever there are overlapping features, that creates confusion, and in a patient with tuberculosis who goes into shock, so this confusion can be only solved if one carefully assesses after looking into the important features that are present in each of these phenotypes. And like in septic shock, one can expect hypotension, fever, but without raised JVP. Vasopressor resistance is unlikely. Hyponatremia may or may not be there. Whereas in adrenal tuberculosis, there will be hypotension, fever may not be there, raised JVP may not be there, but vasopressor resistance and hyponatremia will be there. In pericardial TB, for instance, hypotension is there with or without fever, but raised JVP, vasopressor resistance is there, hyponatremia is not present. So mixed shock is the rule in tuberculosis, but not the exception. So whenever there is a mixed shock, there is a therapeutic paradox in the setting or background of tuberculosis, that central dilemma being that if you start ATT early, there is higher risk of drug toxicity and drug interactions. If we delay ATT, there is progression of tuberculosis sepsis, that is risk, and death. So in unstable patients with high clinical suspicion, empirical ATT is justified. So why starting ATT in shock is so important? Because tuberculosis causes true septic shock. If it causes, then Mycobacterium tuberculosis can induce TNF alpha mediated vasodilation, nitric acid oxide overproduction, capillary leak, mitochondrial dysfunction, and without ATT, the source of sepsis persists regardless of how much fluid you give or how much vasopressors you administer. And the shock is often steroid responsive only, because when ATT is given, the steroids alone suppress inflammation, Without ATT, the risk of uncontrolled bacillary replication and transient hemodynamic improvement followed by collapse is there. So ATT plus steroids is synergistic. It is not optional. So both WHO and ICU literature support empirical treatment in life-threatening disease. So the ATT is the definitive source control because source is the TB in patients with TB-related shock, and the standard regime is the HRZD regime, which is the drug-sensitive tuberculosis in patients. In cases of drug in multi-drug resistance, there are of course other options. We use quinolones and we use streptomycins, and the same we use if the patient cannot be administered oral ATT. But there are special ICU considerations to adjust the dose, particularly if patient is having AKI or hepatic dysfunction following this septic shock. Rifampicin is usually continued unless there is severe liver failure and is modified if MDR-TB is suspected. So the dose modification of the first-line ATT agents with renal dysfunction is to be known, because if you look into the list, rifampicin does not require dose adjustment in patients, in most of the patients, whereas it is required in pyrazinamide and ethambutol only with relation to doses beyond a certain limit. So isoniazid, rifampicin, pyrazinamide are the most potent anti-tuberculous drugs with hepatotoxic potential. So one needs to be careful, and they need to be replaced with a prolonged regime of streptomycin and levofloxacin with ethambutol in patients with liver dysfunction. So this is not alone. Adjunctive ICU therapies are important. Antibiotics should be started alongside. There is no question of delay in antibiotics, as I have shown that studies have been unabatedly showing that delay in antibiotics is hazardous, and de-escalate antibiotics once TB is confirmed. Renal support with CRRT is preferred in cases of unstable patients. The patients should be provided a high protein nutrition, and early enteral nutrition should be the choice. And if the patient is having ARDS, which a large proportion of the patients do have, then the choice for pruning, conservative fluids, ECMO, etc. should be considered duly. While monitoring the complications, we have to be careful towards paradoxical TB iris or immune reconstitution inflammatory syndrome, as well as hepatotoxicity, worsening hypoxemia after ATT, and drug interactions. Now, in a word or two about paradoxical reaction, this is a rapid clinical deterioration after initiation of ATT because of the reconstitution of immunity, leading to an immune response to dead bacilli. The patient develops sudden worsening of pre-existing tuberculous lesions, or patient may even develop new lesions, airway obstruction, splenic rupture, and neurological deterioration in the absence of any alternative cause which can be put forward. So corticosteroids continue to be the mainstay of the treatment. In addition, there are important aspects of care, like patients should ideally be treated in negative pressure isolation rooms. All the procedures prompting droplet formation, like endotracheal suction, bronchoscopy, and nebulization, should be reduced to a minimum. Closed suction should be used, and N95 masks should be provided to the personnel who are managing the patient. Now, there are certain common ICU pitfalls. The first being that ATT will worsen shock. Now, the defense against this comment is that short-term worsening is expected, but normally the mortality rises if the treatment is delayed. The next pitfall may be that steroids cause tuberculosis spread. The argument in defense is that in shock, steroids improve survival and hemodynamics, so it is just the opposite. Third is that septic shock bundle is enough, but the defense is that the TB causes cardiogenic, adrenal, and obstructive shock too. So alone septic shock bundle cannot be cannot bring relief or cure to all patients. The fourth pitfall is that echo can wait. Once the patient improves, it can be more performed in a detailed way. But the defense is that both tamponade and myocarditis are reversible causes, and one should do. So a simplified decision tree should be followed. which should start with sepsis protocol followed by bedside echo. Give cautious fluids, start norepinephrine, send TB diagnostic, start ATT empirically, add hydrocortisone, and reassess shock phenotype daily. So my final take-home message in 5 sentences would be tuberculosis shock is a mixed shock until proven otherwise. Use less fluid and earlier vasopressors because that is the only key, most important strategy which can take us forward. Start ATT early if it is life-saving and if it is not optional. And steroids are protective. They are not harmful in TB shock. And worsening after ATT is because of immune response. It is not because of failure. Thank you.